All right, well, welcome everyone. Happy to see everyone this morning. Today, we're just, as we sort of enter winter respiratory virus season, I already have my first one. We're just going to talk about ways to help our families and our students and our early childhood education settings stay as healthy as possible. Next slide, please. So we're going to talk about, COVID, flu, RSV, norovirus, vaccinations, state guidance, disease prevention, cleaning and disinfection, exclusion, which diseases and conditions require exclusion and not. So it's a very broad presentation. We're going to cover a lot of content, but I'm glad this is being recorded. So if there's places where you need to go back and refer, you'll have that option. And please feel free to put questions in the chat. At the end of my part, I can answer any questions, and then we'll move on to Dr. Trivedi. So next slide. But I didn't even introduce myself. So Dr. Joanna Locke, and I'm the COVID guidance lead for the county. Oop, it just went, oh, there it's back. So what you're looking at here, I just want to talk a little bit about the status of COVID in Alameda County right now, is wastewater levels of the SARS-CoV-2 virus. And you can see we did have a little bit of a wave this summer. You can see that peak that sort of came down within the last few weeks. So right now we're starting to plateau. We know it will come up again in the winter, as it does every year, as most respiratory viruses do. We don't know when, but we're in a little bit of a lull now. And our hospitalizations that were also up in the summer are also starting to plateau. So it's we're in a little bit of a quiet spot. It typically is quieter right now, sort of the calm before the storm. I also linked to our new dashboard. It used to be that we really relied on case count. So when you go to our dashboard, the state dashboard, the media, everyone talked about the number of COVID cases. Because of all the home testing, we don't look at COVID cases in the same way anymore because we just don't know about a lot of them. You know, the over-the-counter tests, the tests we all take in our house, they don't get reported anywhere. So really, we look at wastewater. So we look at this graph, and you'll find this updated every week on our dashboard linked there. And we look at hospitalizations. And those are sort of the two things that we focus most on when trying to figure out what COVID is looking like. So if you go to our dashboard and you don't see cases anymore, that's why. Next slide. So the other things that we can see in wastewater besides COVID are things like influenza, RSV, norovirus. It is, as I said, a quiet period generally right now. We haven't really hit flu season, but it's coming. We're starting to see some increases in RSV. So that's why, vaccinations are a really important topic today, because really you want to focus on vaccines sort of before you're in the thick of it. So October is a really great time to think about and get vaccinations. I also wanted to share at the top of our homepage, we have this blue box that we keep updated. It says the week of October 2nd, but the information is still current. This sort of talks about what we're seeing, sort of new guidance. So in this case, it's a lot about the new vaccine guidance. So if you want sort of a snapshot of like what is going on in Alameda County and you don't want to have to go to a bunch of places, the blue box on the homepage of our COVID website is a great place to go. Next slide. So, our general winter messaging really hasn't changed. We came up with a new tagline this year. We're calling it Have a Health-Wise Winter instead of Winter Wellness. But the information is really the same as it has been for the last few years. COVID is really the greatest risk for people that are older and people that have chronic health conditions, including pregnancy. Pregnancy isn't a chronic health condition, but it is a condition that makes someone more vulnerable to severe disease. So we really want pregnant women to get vaccinated. to stay up to date on their vaccines. But anyone who gets COVID can develop long COVID, and we'll talk more about how vaccine connects, how vaccine is related to prevention of long COVID in a minute. But one thing to note is that, last year, infants less than 6 months, you'll remember that infants of that age can't get vaccinated against COVID. You have to be 6 months and older, had similar hospitalization rates to adults 65 to 74. So like all respiratory diseases, like our littlest residents tend to be at risk of hospitalization in the same way that our oldest residents are. And so I think it's important not to forget that for the population that particularly early childhood is serving. So, staying up to date with vaccines, staying home when sick, and testing for COVID. For adults and high-risk adolescents seeking treatment if testing positive. Over-the-counter tests, I linked here to the federal website. So the federal government is giving out one-time tests again this year that you can order from this link below. Our testing sites have some over-the-counter tests available, and you can still get over-the-counter tests from your insurance company or your health plan. So Kaiser, for example, you can access home testing kits that way. So it's good to have those on hand going into the winter. Our masking guidance continues to align with the state. So we do not have a general masking order in Alameda County. We haven't for some time. But we do still talk about the importance of masks, high quality masks. So that's, your N95s, your KF95s are really effective, even if not everyone around you is masking. So I definitely get my masks out going into the winter. If there's a lot of stuff around, I wear them when I go to indoor public settings. Some people have never taken them off, people that are really high risk. So, if your masks are, in the back of your closet right now, I would suggest sort of getting them out and dusting them off and, thinking about how and when you want to use them going into the winter. Sometimes I'll mask my kids in the winter, like if we're going to go on vacation or if we're seeing family for Thanksgiving who are high risk, I put masks on them, for the week before, because I don't want to, obviously give anything to my high risk family members. I don't want to miss my holiday. So I think it's great that, in other countries, masks have been in use for a long time. And I think it's great that in the US, we have access to high quality masks. Most people own them at this point, and that we can really utilize them when we want extra protection. We do have a mask order in skilled nursing facilities, just so that you know that, for staff in skilled nursing facilities and staff in hospitals and certain outpatient clinics like dialysis centers will have to start wearing them in November. So starting in November 1st, if you go into, a hospital, you'll see staff wearing masks. Next slide, please. So this is a state flyer that I've linked here. We have some local Alameda County flyers coming soon that we'll be sure to share with you, but the state flyer really covers everything that I just covered. It's the same messaging. And what I didn't mention on my slide is, washing hands, cover a cough or sneeze, guidance that existed long before COVID still really remains important for preventing the spread of disease. Next slide. So we're ready for our first poll question. Here we go. Okay. So a 3-year-old who has never been vaccinated for COVID or influenza needs the following. Okay. So the correct answer is actually F. So 2 doses of the Pfizer COVID vaccine and 2 doses of flu, and we will talk about that. Go back to the slides. Okay, so there is an updated COVID vaccine out right now that was authorized by or recommended by the CDC about a month ago. So everyone should get a dose of the new vaccine. For people that have had previous doses, so 1 dose and that's it. Anyone 5 and older who's never been vaccinated, you only need 1 dose now. Young children, however, are still recommended to get more than 1. So for Pfizer, they would need 3 doses, sorry. my poll question was wrong. Pfizer is 3 doses, Moderna is 2 doses. So it depends on the brand because that's how it was authorized. And the reason for this is that young children are less likely to have been infected with COVID. So you don't have the immunity built from infection in the way that an unvaccinated adult would likely have at this point. And then unvaccinated immunocompromised persons need a multi-dose series as well. So it's important to know for the little ones that you're serving, they'll still need 2 or 3 doses if they've never been vaccinated. If they are vaccinated, they've had their 2 or 3 dose series, they only need the 1 dose of the updated vaccine. Novavax, the updated Novavax vaccine, is also authorized now. So for people that want an alternative to an mRNA vaccine, we still have Novavax. That's only for 12 and up, though. It will come for there'll be a version for younger kids later, but it hasn't come out yet. But for adults, for staff, for families, a 2-dose series for the unvaccinated, just 1 dose if you've been vaccinated before. So they're not really calling it a booster, but for most of us, we can think about it in the same way that we think about our flu shot. And this new vaccine targets the XBB.1.5 variant. So it's the variant that was around in the spring, and everything that's around now are descendants of this vaccine. So the updated vaccine is a better match for what is currently circulating than the previous vaccine. So it's the same way that the flu shot gets updated every year, right? Because you want a really good match between the specific virus that's circulating and then what your body's building immunity to. And insurance, including Medi-Cal, will cover the cost for most people. For adults who are uninsured or whose insurance doesn't cover vaccines, the federal government has rolled out something called the Bridge Access Program, and I have it linked here. And I can share a flyer in the chat later giving locations in Alameda County where uninsured adults can get the vaccine through the Bridge Access Program. All children in Alameda County are eligible as part of the Vaccines for Children program. So the goal of all of this is for everyone to still be able to access the vaccine for free. It's a little bit trickier now because it's not the sort of anyone can go to any vaccine, clinic that exists and get their vaccine. It's sort of become part of our healthcare system now. So you have to think more about where you're going to go get it. But the hope is that between it being covered by insurance and the Bridge Access Program, that people will still be able to get the vaccine for free. Next slide. So flu, I'm trying to call it influenza as I talk about it this year because the word flu gets thrown around to cover lots of different things. But I think it's worth remembering, influenza is a big deal. Influenza can be very dangerous, again, for our littlest residents and our oldest residents, and it is important to stay up to date on your flu shot. I think some people hesitate because they hear, well, I can still get the flu, which remember is also true for COVID, but the purpose of these vaccines is to keep you from getting really sick, right? So I, for one, would rather have one of these viruses on my sofa rather than in the hospital. And so that's how I think about it. And you can see the CDC campaign here. A flu vaccine can take flu from wild to mild. So they have a whole campaign with lots of different animals. And I think the point is, we should stop trying to expect these vaccines for these respiratory viruses to just, you're never going to get it ever. It's that you don't end up in the hospital and you don't get really, really sick. And you don't hopefully die. So those are sort of the important roles that these vaccines play. So like COVID vaccine, for the littles, they should get 2 doses their first flu season. So an unvaccinated 6-month-old to 8-year-old should get 2 doses their first season. After that, they only need 1. And we just looked at our flu vaccine numbers for last year, and you can see only 11% of our under 5s got both doses. That is a huge proportion of kids who are unvaccinated or under-vaccinated, and that they are a higher risk group for getting really sick. And only 60% of our older adults were vaccinated. So we want to work really hard to try to get these numbers up. And as I mentioned, like with many things, older adults, young children, pregnant persons, people with chronic conditions are at higher risk for severe influenza disease. Next slide. So we have good news this year. We have RSV vaccines for the first time. So you probably heard about RSV in the news last time, and most people think about it as being a virus that affects young kids. So we had a lot of kids in the hospital with RSV last November. It also affects our older adults. Older adults can get really, really sick from RSV, and we now have vaccines to protect both of those groups. So adults over 60 can get an RSV vaccine. Pregnant women can get an RSV vaccine. And what that does is it protects the baby during their first 6 months of life because the antibodies get passed to the baby. Or if the pregnant person does not get vaccinated, there is now a monoclonal antibody that we can give to babies during their first RSV season that will prevent them from getting really sick. And this really is good news because this was sort of one of the places where we really didn't have, any protection. And finally, we have protection for our highest risk residents. So please spread the word that this vaccine exists and that there's something that can be given to babies as well. Very important. Next slide. So just to go over state guidance, as you probably know, during most of COVID, the state had K-12 guidance and then it had childcare guidance. And this year it has combined them. So you can see here a screenshot, and I have it linked from the slide. There's guidance for childcare and K-12 schools, all at once. And it really covers, it's not just focused on COVID, it's on preventing and managing communicable diseases, because as you know, a lot of the principles are the same. Focuses on vaccination, ventilation, testing, staying home when sick, hygiene, and cleaning. So if you haven't checked that out, please do so. Next slide. And just a reminder, you've probably seen the Swiss cheese slide many times before, but it's really about layers of protection, right? So everything that you do helps reduce your risk and the risk of the kids in your care from getting sick, right? So it's really all of these things work together. Next slide. So this is the guidance for COVID isolation. So this is state guidance. In Alameda County, we do not have an isolation mandate anymore, but the state still does have isolation guidance. So staying home for 5 days. And then returning, you can see if symptoms are improving and fever has been resolved for 24 hours. And then masking is recommended for a total of 10 days. And obviously there's the same limitations on, not masking under 2. And there are certain, people with disabilities who are unable to mask. And obviously you'd never put a mask on a sleeping child. And you can see that there's a little exception that if you have at least 2 negative tests, you can end masking before day 10. But this is not for staff. So I'm going to go over the CalOSHA staff guidance in a second, but this is for this would be for, for children. And this is a recommendation. So these are not, this is not a mandate anymore. Next slide. So CalOSHA has requirements for staff. So for employees, you are required to stay home for 5 days, and the same return to the workplace rules apply. So if your employee is getting better, fever-free for 24 hours, they can return after 5 days, but they're supposed to wear a face covering for a total of 10 days. And also you have to provide a written notification to employees or contractors who are exposed to COVID at the workplace. And in addition to people returning from isolation, people who are exposed should wear a well-fitting mask around others for a total of 10 days. So I've linked here to the CalOSHA requirements if you want to take a review for that. Next slide. So exposure notification. So how you do this for families is really up to you. There are some schools that still notify families of any COVID case that they hear about. You know, that's difficult for really large K-12, schools to be able to track it in that way. So some large schools now will just sort of send out a blanket notification during the winter, basically saying, there's a lot of COVID cases in the school right now. Smaller schools, it's easy to notify when there's been a case. If it's easy for you to do that, it's not a bad thing to let families know that there's been a case in your setting. But I think this last bullet is really important, is that just because there's not a notification doesn't mean there's no COVID, because not everyone is symptomatic and not everyone tests. So I think part of it is, don't assume just because you haven't gotten a letter from your school that there's no COVID. If your kid develops symptoms that could be COVID, it's good to test. Don't just say, well, I'm not even going to bother testing because I haven't gotten an exposure notification. If you're symptomatic, test. Next slide. So this is just how early childhood providers can order at-home tests for the uninsured. So you have until October 31st, and you can see the link there where you can order them. So you can request up to 8 tests per uninsured individual. And and you can see the asterisk at the bottom, it's for you, not to share with parents. But definitely let parents know that they can order from the federal government at the link that I shared in an earlier slide. Next slide. So reporting COVID cases, we are transitioning to align childcare reporting with the thresholds that we've used in K-12 and elementary schools for a while. So 4 or more within a 7-day period. Our website has not been updated yet. So if you go there, you're going to see the 3 or more. But know that that's sort of that's a guideline. If you have fewer than that and you're concerned, like you went from 1 case to 4 cases overnight, or you have questions or something is concerning you, you can always contact us. You don't have to wait until there are 5 or more. That's sort of the latest that we want to find out about, but definitely contact us if you have concerns prior to that. Next slide. And this is just a slide about Medi-Cal redetermination. You'll remember with the end of the federal health emergency, redeterminations kicked back in, which means families now have to do their annual re-enrollment. And one of the important things is to make sure that our social services agency has updated contact information, because if the packet goes to the wrong address, the family's not going to know that they're going to, fall off Medi-Cal. So make sure families know, if you have moved in the last few years and you think your, re-enrollment date was sometime in the fall, update their contact information to make sure that they get the packet when it's sent out, and they can always call and find out and make sure that they haven't sort of missed a deadline, because it's really important. We don't want people, losing their Medi-Cal. Next slide. That might be the end of mine. It is. All right. I think I saw some questions in the chat, and I can see Sabrina's been answering some of them, and Dr. Trivedi's been answering some of them. Catherine, are there any that you want me to answer verbally?
Joanna, I was hoping I responded to, I think, Melanie's question about vaccine rollout. I know there have been a lot of hiccups with getting the booster out, and I referred her to vaccines.gov, but just wanted to see if you have any other thoughts for her about that.
Yeah, it has been slower than everyone had hoped. There's also the state My Turn website, which I can also drop in the chat. But I think if someone has a healthcare provider, I think just continuing to check in with their healthcare provider. You know, most pharmacies won't vaccinate little ones, so they really need to go to their healthcare provider. So I think it's just continuing to check in. I feel like I just got the Kaiser email recently that they were finally able to vaccinate. So it's unfortunate because we've just heard a lot of stories about people being turned away, and I think people are eager to stay up to date, and it's frustrating when you have to go back more than once. So appreciate everyone's patience with the rollout.
Dr. Locke, can I just add one thing related to getting tests from CDPH for those staff and families that may be uninsured? I just wanted to make clear, CDPH isn't asking for you to like prove, you know, that folks are uninsured or anything like that. You know, they are trying to make this as accessible as possible. So, you know, please take advantage of that. I know there's so few ways at this point to get over-the-counter testing for kids and families, and that this resource exists is, you know, is a great thing that it does still exist through the state. So if you have families who meet that threshold, or staff members, please do take advantage of it. Thanks.
Thank you, Sabrina and Dr. Trivedi, Dr. Locke. Is there any other questions, folks, that have? Looks like we had some of the links posted into the chat, so you're welcome to check those out. The Cal OSHA requirements, myturn.california.gov, and some of the programs, CDPH.
And I just dropped the new COVID vaccine schedule in the chat.
Sounds good. We could have Dr. Trivedi will be doing our second part of the presentation.
Great, thank you. While we're getting the slides up, I'll just say that I am the Director for Clinical Guidance at the Alameda County Health Department, as well as the Communicable Disease Controller, which means that we are responsible for limiting the spread of transmissible diseases throughout the county. And we have a pretty large team of public health nurses that really run our program. And I just want to acknowledge that Dustin Heaton, who's one of our who is our team lead for our acute communicable diseases team, is on the call as well. So maybe Dustin, you can answer any questions that pop up into the chat. Great, next slide. So I'm sure many of you are aware of a lot of the things we're going to talk about, but I wanted to first note that there are certain reportable diseases and conditions that are required to be reported to us by statute. This is under Title 17 under the California Code of Regulations. And if you go to this link, you can actually see how quickly each of these different diagnoses are supposed to be reported to us. So measles, for example, is supposed to be reported right away via a phone call, as you can see in that chart. And chickenpox also is supposed to be reported as quickly as possible. So just make sure that you all are aware of which diseases are supposed to be reported to the local health department and what the urgency is in terms of how it's supposed to be reported. Next slide. So there are certain symptoms and signs that children have that require, emergent care. And recently CDPH has put together some recommendations that are also linked here with exactly what those signs and symptoms are, right? So if a child is acting strangely, they're not as responsive or as unconscious, that would be a sign or symptom requiring emergency care. So in that situation, you obviously wouldn't call us, you would call 911 first. And they've made it pretty clear in this guidance what those signs and symptoms likely are. So also good to make sure your providers are aware of what these signs and symptoms are that would require calling 911 immediately. Next slide. And then, there's our response to ill children, which we have often in our classroom. So certain symptoms in children may suggest the presence of a communicable disease, and sometime temporarily excluding an ill child may decrease the spread of the disease in a child care setting. I think this is slightly different than what I thought was in the slides, but we recommend exclusion varies really by the disease or an infectious agent. And then the other thing I want to note is that it's really recommended that childcare and preschool providers, as well as schools, have policies that are clearly written for guiding the response in children and staff, right? So if you have these policies that are in the student handbook, that are given to the parents when school starts, or updated whenever they're needing to be updated, that really does help with making sure parents and guardians and staff understand when we're going to temporarily exclude children and what the readmission criteria really is. So really trying to address this on the front end rather than trying to address this on the back end is highly recommended. Next slide. When a child becomes ill but does not require that immediate medical help that I mentioned in a couple slides before, we need to make a determination about whether or not they need to be sent home or should be temporarily excluded. I want to be clear that most illnesses do not require exclusion, right? So most things, most diagnoses do not require exclusion. But a designated staff member should determine whether the child's illness meets certain criteria. And what we really recommend is to look to see if the child can participate in activities at school, right? We want to make sure that whatever they have, they're still able to participate in activities, whatever they have doesn't mean that there's more care that needs to happen from staff members than they can provide without compromising the health and safety of other children. And of course, poses a risk of spread of harmful diseases to others based on specific excludable conditions. So it's really important to keep this stuff in mind. And I will say too that in an era post-pandemic where we have excluded children for so long, and we know that the ramifications of children not being in school, we really want to be as permissive as possible about getting them back into school, right? We don't want to just keep them out of school just because we're not really sure what's going on with their symptoms or signs. We really want to try to get them in school as much as possible, but also be safe and not transmit harmful diseases to others. So if any of these criteria are met, if they can't participate, if they're requiring more care than staff members are able to provide, then they should be excluded. Unless their pediatric healthcare professional, their pediatrician, determines that the child's condition does not require exclusion. But this is where the local health department really comes into play, that we want to talk to you and we can give you advice about what to do in these types of situations, right? That's one of the roles that we are here to provide to you. Next slide. And then I thought this had some animations, maybe it didn't pop up, but one of the things I did want to mention is if there is an outbreak of any infections or symptoms in the school, I think it's important for you all to understand that you're supposed to be calling your local health department to report the outbreak. And we, again, will help you determine how and if to temporarily exclude any children based on their symptomatology, right? So we're actively actually consulting with a school right now about one child that was diagnosed with strep throat and other children that have a very similar presentation. And so we're giving advice to that school about how to help prevent spread of strep throat to additional kids in that classroom, right? So there's specific guidelines about that. So on this slide, what I had meant to put on here is about fever. So typically fever is something that we have not wanted kids to be in school with. However, the guideline now from CDPH is a little more permissive again around fever. One thing I want to note is if a child has fever alone with no other signs and symptoms, but that may not be a good reason to exclude them from school. Having a fever could be because a new tooth is coming in, for example. Fever doesn't always correlate with a communicable disease. So that's something really important to note. But if fever is accompanied by another sign and symptom, could be a reason to consider whether or not the child should be excluded. So the other thing I want to note is CDPH in their recommendations do have a little more permissive language than we've had before in their guidelines, and you'll see this here that I have on the screen. Again, we would recommend calling our health department to discuss an outbreak situation. So definitely make sure to do that. And then the other thing is that these are just recommendations from CDPH. These are not necessarily the statute. So if your institution, if your organization wants to be more restrictive about children being able to come back to school with a fever, for example, you could put that in your handbook. I would encourage you to call us so we can talk to you about it. But this is something that definitely has come up. Fever alone is not a reason to exclude children from school. Oh, I wish I could show you what's behind this table. But anyway, we'll move on to the next slide. Can we move to the next slide? Yeah. Thank you. So diarrhea is another symptom where we do recommend temporarily excluding the child. Diarrhea is defined by stool that is occurring more frequently or is less formed in consistency than usual, and the child is not associated with changes of diet. Excluding children whose stool frequency exceeds 2 stools above typical for that child is the AAP recommendation, which is what is on your slide here. And then they have actually specific recommendations on when readmission is suggested. For example, the bullets on the bottom: diapered children having their stool contained by the diaper, even if the stool remains loose. Toilet trained children do not have toileting accidents. Again, this all goes towards them being able to participate in activities at school and staff not being required to provide much more additional oversight to these children. And so we can still have a learning environment in the classroom. So I would refer you to these slides if you have any additional questions, and please feel free to reach out to our team as well. Next slide. And then vomiting. Vomiting, again, is 2 or more times in the previous 24 hours, unless the vomiting is determined by a pediatrician to be caused by a non-communicable disease, which is also possible. Other specific excluded conditions include abdominal pain, mouth sores with drooling, rash with fever or behavioral changes, and skin sores that are weeping fluid. So there are lots of different excludable conditions. Again, please feel free to call or email our group if you have questions about any of these things. Next slide. And I would really encourage you to put these recommendations in a parent handbook. So, can you go back one more slide? So that parents are aware of what things are required for their child to be able to stay in your classroom. The other thing I want to mention is if there are specific conditions that a child is diagnosed with, for different specific conditions, we do have specific exclusions. For example, with strep throat, you are supposed to be excluding the child until they've received antibiotics for 12 hours. So that won't mean that all their symptoms are necessarily gone, but once their antibiotic is in their system for 12 hours, they are no longer contagious, which is why we allow them to go back to school with strep throat in that situation. So if there is a specific diagnosis, then it's really easy to look that diagnosis up and see exactly what the recommendation is in terms of when we allow kids with those diagnoses to go back to school. Great, next slide. So I think we have a poll question for you. So the poll number 2 says a 5-year-old with a fever, but no other signs and symptoms should be temporarily excluded from school. True or false? So hopefully I discussed this in in the last part. Oh,
Okay, it's gonna share the results.
great. Great. I don't know how many people answered, but that is correct. So you would not exclude that child just because they have fever. They would need to have another sign or symptom to consider exclusion. So that's great. I'm glad you guys got that piece. So let me go back here to the chat for a second. So Dustin wanted to clarify a point that if a child under 5 years of age is diagnosed with either Shigella or Shiga toxin producing E. coli or typhoid fever, which is another type of salmonella, they will need to receive clearance from us before they can return to daycare or preschool. So we help manage those types of situations about when the child is allowed to go back to school. And usually we are working with the parents and the providers directly on this. But we will definitely let we are allowing the child to go back to school when they have cleared. So we will be managing that directly. And then for Gloria, for hand, foot, mouth disease, I'm actually going to talk about that in a moment so we can get more into hand, foot, mouth disease in a moment. Great. Let's go back to the slides.
I'm gonna put the updated slides on here. Hopefully that's the right one.
And then one thing, so Sabrina, thanks for putting the considerations of when a child has symptoms of illness in childcare or school guidance from CDPH. What I had said is that those are just recommendations. So just keep that in mind when you're looking at them. Again, they're more permissive to letting kids back to school. And then the safe learning at acgov.org is a great email address to email if you have specific questions, especially around COVID. If you have questions about communicable diseases, I'll let you know what the acute CD group's email is later in the presentation. Okay, great. So I'll just mention that when you're evaluating temporary exclusion, the largest emphasis is on whether the child can participate really in school activities. So that's going to keep coming up when you're evaluating different diagnoses. So we also looked at our data and looked at outbreaks reported among schools and childcare. And this is data from 2018 to the present. So our group, our CD group, has worked on 50 GI and non-COVID respiratory outbreaks in schools and childcare settings. So in the graph on the right, you can see the blue is outbreaks reported in schools. The light pink is outbreaks reported from the childcare settings, and the kind of the more pink color, darker pink color is outbreaks reported from camps. So you can see in 2018, 2019, we had a significant number of outbreaks reported from our school setting. 2020, 2021, because kids are no longer in school as frequently, we're not having any school outbreaks, only childcare outbreaks. And we're seeing those number of outbreaks start to go up in 2022 and 2023. Across all of these outbreaks, a total of 1,749 people were ill. So some of these outbreaks could be really, really large. And the average median age of those ill was 8.2 years old. So, a large number of these are happening in elementary schools, but we certainly do see our fair share of outbreaks happening in the early childhood ages as well. Next slide. I have a little more of a breakdown, I think, of the outbreaks here. So of the GI outbreaks, which were the majority of our outbreaks over this time period, 38 outbreaks were due to suspected or confirmed norovirus. So that seems to be a large number of what we take calls about in terms of outbreaks. 2 outbreaks were related to Shigella. 13 outbreaks, GI outbreaks, did not identify a cause of the outbreak. And the symptoms that are most commonly reported to us in all of these outbreaks are fever, diarrhea, vomiting, nausea, abdominal cramps, and a headache. And the median duration of illness for these outbreaks was 16 days. So it did take us a while to really limit the spread of diseases in a lot of these settings, which is why it's really important for you all to report to us as quickly as possible so we can help put in control measures to help prevent additional children from getting ill. So of the respiratory outbreaks that were reported, one outbreak was a respiratory syncytial virus outbreak, one outbreak was strep throat, and one outbreak was influenza-like illness, so a flu-like illness. And the symptoms under the respiratory outbreaks were most commonly fever, cough, runny nose, and sore throat. And the median duration of illness for the respiratory outbreaks was 19 days. So again, calling us more quickly will help decrease that median duration of outbreaks. Next slide. Okay, so I think we have our next poll question. Great. So Alameda County outbreaks reported from childcare and early childhood education and schools in 2022 were mostly respiratory viral outbreaks, true or false? So what did we see mostly in 2022? Okay. So 67% said true and 33% said false. So we mostly saw GI outbreaks in 2022. GI outbreaks is our most common type of outbreak in Alameda County that are reported from the school setting. Great, next slide. So that brings me into what I'm going to talk about next. I'm going to briefly talk about norovirus because norovirus is again the most common etiology for outbreaks in our school setting. Great, next slide. I'm going to go over this pretty quickly, but I wanted you all to have this in your back pocket in case you do end up with a norovirus outbreak in your setting. So norovirus is a highly contagious virus and is the leading cause of GI illness in the United States. The symptoms that norovirus causes are nausea, vomiting, diarrhea, and abdominal or stomach pain. Next slide. Some people call this stomach flu, and this is why Joanna mentioned she's trying to use the term influenza for flu because we use the word flu a lot. So some people call norovirus stomach flu or food poisoning. A couple things to note is there are many different types of norovirus, so you can get it more than once. So just because you've had stomach flu one time, it doesn't mean you can't get it again. And it's really important to understand it takes a very small amount of norovirus particles to make you sick, fewer than 100. My favorite story from when I was at the Centers for Disease Control is about an elderly tour group that was touring New England from Los Angeles, and they are flying back from Boston to Los Angeles on a direct flight on an airplane. One person has norovirus on the plane when they get on the plane in Boston. By the time they get to Chicago or Chicago, they have to divert their airplane because so many people at that point on the airplane now have norovirus. So this is a very contagious virus. Next slide. Norovirus outbreaks are more common in the cooler months. So we typically see them between November and April. And as I mentioned, infection spreads very, very quickly, especially in your settings in schools and childcare centers and places like airplanes that are small enclosed places. Next slide. So you'll see there's a theme in our outbreak definitions. It's not as hard as 2 cases of infection define an outbreak. So usually we say an outbreak, the outbreak definition for many different diseases, but specifically in norovirus is more persons with vomiting or diarrhea than would usually be expected in the facility for that time of year equates a potential outbreak. So if you're seeing more cases of vomiting and diarrhea in your kids, and you have more kids that are out of school because they can't participate in those activities at school, you might have an outbreak on your hands. So for example, if 2 children in the same classroom are sick with vomiting or diarrhea within 1 week, and that number of illnesses is more than you typically see for that time of year, then an outbreak may be occurring. So it's really important to continually monitor for an increase in illnesses in the entire school. Important to know why kids are out, what the reason is for them to be out. And I'm sure you guys are very well aware of that. Next slide. So how is it spread? People with norovirus shed billions of viral particles in their stool and their vomit that can easily infect others. What happened on this airplane that I was mentioning earlier is that the index case was using the bathroom and also having a couple of accidents in the aisle with vomiting, and that actually ended up infecting many more people on the plane. So you could be infected directly by an infected person. You can eat food or drink liquids that are contaminated with norovirus. You can touch objects that have norovirus on them and then put them in your fingers. And then you can share utensils or cups with people who are infected with norovirus. And thanks, Dustin, for answering the question that norovirus is not spread through the respiratory system. Next slide. And thanks for the questions, Kelly, Melanie, others. It helps us understand what you guys are understanding and where any of your questions are. And please, that's the reason we're doing this. So I appreciate the questions. So how long does norovirus infection last? Most people recover within 1 to 3 days, but can continue to shed the norovirus particles in their stool for several days after their symptoms disappear. People with norovirus should drink plenty of liquids. This is another thing to emphasize with any of your children that have diarrhea or vomiting, or diarrhea specifically, that they really need to keep hydrating. One of the reasons we see these patients in the hospital or even in outpatient clinics is because they have gotten dehydrated from all the diarrhea that they're dealing with. So if they can't keep liquids down because of all the vomiting, I would recommend that they go see their pediatrician. Next slide. So students and staff that are ill with vomiting or diarrhea must stay home while they're sick for another 48 hours after their symptoms go away. This is for norovirus specifically, if that's what we're talking about. It takes about 48 hours after their symptoms to go away for them no longer to be contagious. Next slide. So this emphasizes what we all should be doing. We should be regularly washing our hands, especially after using the bathroom and before eating. Alcohol-based hand sanitizers are not recommended in this situation where you're dealing with an infection like norovirus because of the limitations of alcohol-based hand sanitizers getting rid of stool on the hands. So if there is a concern about norovirus, we really want to encourage students and staff to wash their hands with soap and water. Next slide. And then in terms of cleaning and disinfection, classrooms, cafeterias, bathrooms should all be regularly cleaned and disinfected, and also high-touch surfaces, right? So door handles, handrails, light switches, all the things, phones, playground equipment, all the things that kids are touching all the time. We really want to encourage regular cleaning and disinfection of these high touch surfaces. Next slide. And then preventing norovirus. So this is really how we clean an area that has been infected with norovirus. We want to encourage putting on gloves, gowns, masks, eye protection, shoe covers if available. You want to remove the vomit and the feces using disposable materials, not reusable materials. You want to clean the area with soap and water, and then you want to use a bleach solution to disinfect. And then if you're unable to use bleach for whatever reason, you can use another disinfectant from the EPA List G. Next slide. And I think I have how to prepare the bleach solution on this slide. And then be sure to prepare the fresh bleach solution daily. And then when you disinfect, leaving the bleach on the surface for at least 5 minutes, covering the entire surface, and then rinsing thoroughly with water after that contact time has been achieved. again, please keep these slides as reference when and if you end up in a norovirus outbreak. Next slide. The other thing that's important to know is I know in a lot of early childhood education classrooms, there's a lot of carpet and upholstery. So you really want to carefully remove the vomit and diarrhea from those areas as well, and clean with soap and hot water. We also recommend steam cleaning for 5 minutes or 1 minute, depending on the temperature after, but you really don't want to vacuum in order to minimize the aerosolization of the particles into the air. Next slide. And this is just a prevention summary, right? So staying home when you're sick, washing hands often, regularly cleaning and disinfecting, and then cleaning and disinfecting vomit and feces appropriately and not aerosolizing particles into the air. All really important things to help prevent norovirus outbreaks. Next slide. I think that might be done, or maybe not. So in terms of guidance, if you have a sudden increase in illnesses due to vomiting or diarrhea, there is a wonderful toolkit on the CDPH website that maybe Sabrina can put in the chat, called the Norovirus Toolkit for Schools and Childcare Center Outbreaks. We will refer you to that. But in addition, you are required and requested to report the outbreak to us, the local health department. And when I say us, I mean the Alameda County Public Health Department, the Acute Communicable Disease section. I have our phone number listed there. And then this is the email address that you should email if you have an outbreak. But also during work hours, 8:30 to 5, please feel free to call us directly. We always have a nurse of the week who is available to talk with you at all times during office hours, during regular working hours. Great. Next slide. I think it might be. Oh, so here are more references for norovirus. And then I think we have a poll question. And while you're, oh, maybe not. Okay, so sorry. Let's do hand, foot, mouth disease really quickly. I think Dustin answered some of these questions in the chat. Let me just answer Kelly's question about the best way to hydrate to recover from diarrheal dehydration for kids. Yes, Pedialyte is a great option for kids. Anything with electrolytes in it, so Gatorade, Pedialyte, all of these things could be helpful. And then the best way to rehydrate for adults, same thing. You know, they also can drink things like Pedialyte. I'm not remembering the other word for what we recommend in adults, but anything with electrolytes in it that if they are able to keep down is really helpful. But that is usually the biggest reason that we end up seeing patients in the hospital with diarrhea. It's not the diarrhea itself, it's that the diarrhea causes the dehydration, and then they have to deal with dehydration at which is really problematic for our whole system. Yeah, Gatorade example is a great example of what adults can drink to help prevent dehydration. And then, you know, another thing, I'm sure you are aware that more concentrated the urine is, so the darker your urine is, you can tell how hydrated the person is. So what I often tell my patients is, you know, when you're trying to hydrate well from a respiratory virus illness or from diarrhea or vomiting, you monitor your hydration based on how yellow your urine is. So the lighter your urine is, the better you know you're hydrating yourself. So if you see really concentrated urine in children that's really dark yellow, they're not hydrating well enough. Great. Okay, so now I'm going to quickly talk about hand, foot, mouth disease. I think Dustin may have already answered some questions about this in the chat. Just quickly, I would refer you to CDC for a lot of this information. Hand, foot, mouth disease is caused by a group of viruses in the enterovirus family. Coxsackie A16 is the most common cause of hand, foot, mouth disease, but there are many, many Coxsackie and enteroviruses that have been associated with hand, foot, mouth disease. This is a pretty common illness that usually affects infants and children under the age of 5, but adults can have it as well. My husband actually had it when he was 19, so it's also something to have when you're an adult. Typically, hand, foot, mouth disease occurs during the summer and autumn months, but I will note, are getting a lot of questions about hand, foot, mouth disease from our providers already now. It seems like that's one of the most common phone calls we're getting right now about hand, foot, mouth disease. In terms of symptomatology, usually starts with a fever or poor appetite, malaise, and sore throat. And about 1 to 2 days later, after the fever starts, you'll start to notice painful sores, usually that develop in the mouth. These begin as small red spots, usually in the very back of the mouth, that often blister and then can ulcer. And then the skin rash develops 1 to 2 days later as flat or raised red spots, sometimes with blisters. And characteristically, you see the rash first on the palms of the hands and the soles of the feet. So that's like kind of classically what hand, foot, mouth disease looks like. But it also can appear in other places as well. Next slide. So in terms of transmission, this is a virus that is transmitted via the respiratory tract, so via respiratory secretions. So saliva, sputum, and can also be transmitted via feces. So close personal contact with the infected individual, such as caring for individuals with illness, diaper changing, or sharing contaminated toys, can be an exposure. Touching surfaces or objects contaminated with virus and then placing hands in their eyes, nose, or mouth can also be a way of transmitting this virus also. And then the other thing is the environment. Enteroviruses can remain on the environmental surfaces, so high-touch surfaces, for a very long period of time. So there can be some transmission at home via environmental surfaces. You're most contagious during the symptomatic phase, while the case is shedding virus via the respiratory route, via blisters. The fluid from the blisters are also contagious, and feces. And then the other thing to note is the virus may persist in the feces for days or weeks, even after the symptoms resolve. So persons working with young children should pay special attention to environmental hygiene. Hand, foot, mouth disease is very common in these settings. Okay, next slide. And then this just talks about infection control, prevention in with your cases, and with the contacts and additional prevention education. Dustin, I didn't follow all of the chat about hand, foot, mouth disease. Do you want to emphasize anything else that you saw in the chat? I know you wrote a lot.
I think I'll just say that generally, if the children are mildly ill and don't have, a lot of blisters, generally they should be allowed to attend. But if they have a lot of blisters, particularly in the mouth, I think that can be hard to manage, and could be a lot of drooling, and that's probably, like you said, when they're most contagious. So that would be the time period to exclude them. But once those have resolved, they typically should be allowed to return to school. I think one thing to note also, though, is that because people may shed the virus asymptomatically, or they may shed the virus in their stool for several weeks after an infection, excluding children from school is likely not going to halt transmission. So I think a lot of times this is unfortunately something that kind of just has to take its course, and you can take measures definitely to prevent transmission, such as cleaning and excluding kids during their most infectious phase when they have those blisters. But it's not uncommon for us to see settings that continue to have cases for a week or more, just because of the nature of this disease.
Thanks for that. Great. Again, great reason to call us if you have questions about hand, foot, mouth disease, specifically in your situation. And then Kelly asked, how come it usually occurs in the summer and fall? I feel like I used to know the answer to that question. I think because of just the nature of children and interacting closely with each other during that time period. But I don't know, Dustin, if you know why we mostly see it in the summer and fall months. I think we mostly see Coxsackie and enteroviruses in the summer and fall. But yeah, not something we typically see later in the year, although I think I've also heard about it happening in the winter months as well. Great. Next slide. I think we maybe have a poll question. Great. Poll question number 4. Increases in student and or staff illnesses due to vomiting and or diarrhea should be reported to the Alameda County Public Health Department, the acute communicable diseases section. True or false? Great. You guys all got that right. Yes, you should be reporting an increase in student and or staff illnesses to us. Great. Next slide. I think I might just have a couple of things about head lice really quickly. Head lice, while definitely a nuisance, does not transmit disease to humans. Traditionally, head lice policies in schools have emphasized that a child infested with head lice could not return to school until they had no nits, which is called the no nit policy. But there has been a lot of documentation earlier in 2000 and 2001 that there's no evidence that a no-nit policy prevents or shortens lengths of outbreaks. So the American Academy of Pediatrics and the CDC are all opponents of a no-nit policy. Next slide. CDPH also recommends a no lice policy. Early detection of head lice infestations through routine screening by parents or caregivers, treatment of children found to have live lice, and then distribution of educational material to the school staff and parents on head lice. And there are brochures that are available in English and Spanish around that. Great. And Joanna mentioned hand, foot, mouth disease going through her son's classroom when he was a toddler in December. So again, you know, when we as epidemiologists, we give you what we're seeing in the data, but it doesn't mean that there can't be things happening outside of those generalities. Okay, so when to contact the Alameda County Public Health Department. You all should call if you have a question about when a child or a staff member has a reportable disease. Again, remember the list of Title 17 reportable conditions and diseases. Absolutely, please call us for any of those reportable diseases in a child or a staff member. If a reportable illness occurs among staff members, children, or families involved with the program, or if you need assistance in managing a suspected outbreak. And again, what I said earlier is generally it is whatever number of illnesses are above what you usually see in your setting. So it could be 2 or more unrelated children with the same diagnosis or symptoms in the same group within 1 week. And then I just noted here that clusters of mild respiratory illnesses and ear infections are pretty common in the childcare setting and are generally not needing to be reported. Great. Next slide. Again, to report outbreaks, please email us at acutecd@acgov.org, or you can call the phone number listed. You're welcome to call us for any reportable communicable disease questions. And then for non-clinical questions about CDPH school childcare guidance, you can email that safelearning@acgov.org email. So I guess the take home from this is really acutecd@acgov.org or safelearning@acgov.org are your 2 email addresses at the county to help you throughout this next respiratory and, you know, I guess school year. Next slide. I think that's it. Great. So I think we have a few minutes left to answer any additional questions. Maybe Joanna can come on with me as well, and we can see if we can entertain some more questions from you all.
So you're welcome to unmute yourself if you have a question. We'll open the floor to everyone.
You all are experts now. You now know all the things.
Just check in the chat, see what's going on in the chat, if there's any questions there.
I had never heard of drip drop, so that's good to know.
I was going to say that too. I have not heard of that either.
Yeah, it's really tasty. They were headquartered in Oakland for a while, but basically it was this doctor who did, medical mission type trips. And out there, a lot of people have diarrhea and are dehydrated. So they created this like product and it tastes really good. So I recommend it.
Thank you for sharing that. So there's a question by required reporting. There's a question about required reporting and what that actually means.
Okay, I'll start and then Dustin, you can add. So under statute, the reportable diseases and conditions that are listed under Title 17, which I think may be somewhere in your chat, but it's definitely in my slides. Those conditions are required to be reported. Often we are getting laboratory results from providers if there is a laboratory, a lab that's associated with that condition. So often we are also hearing about it from the provider. So providers are required to report to us on those conditions. Any outbreaks that are happening in your setting, you are supposed to be reporting to the local health department to notify us about those outbreaks. So I would say those are like the two required reporting settings that we're talking about. Dustin, would you highlight anything else?
Not necessarily. I mean, if I put the link to the reportable diseases in the chat, I'd say, I mean, I think there's 80 something plus diseases on there. And I think the majority of these are things that you're probably not going to hear about or know about. And like Dr. Trivedi said, we really rely on the healthcare providers that are diagnosing these individuals to report them to us. But there may be instances where, you hear from a parent that a child was diagnosed with, I don't know, measles or chicken pox or something like that. We encourage you to give us a call to let us know that you've heard of that, and we can look into it further to see if it's something that should have been reported to us. I think the main takeaway is that, we can't rely on healthcare providers to necessarily notify us of outbreaks because they may not be aware of what's going on in schools and other community settings. So letting us know when you have an outbreak of illness or, an increase of individuals with things like, vomiting or diarrhea, we're really here to help. And, we're friendly, I swear. We're not we're not a regulatory agency. And I guess another thing to point out is that if you do have an outbreak, if you're a licensed facility, you should also, notify your licensing department that you've had an outbreak, and also let them know that you've reached out to public health so that they know that, you're seeking appropriate guidance and that you're going to implement the guidance that we've provided to you.
Thank you for sharing that information, Justin.
Yeah, I would just emphasize too that, this is a team sport, right? The way we're going to help limit transmission of diseases in our communities is if we all work together. So we're hearing from providers, we're hearing from you all. That's the way we're going to be able to limit these infections.
We have a couple of comments. There's another question in the chat. How often do providers report to you, and like at the end of each business day?
Yeah, so providers are required to fill out something called a confidential morbidity report, a CMR, and they fill that out and they'll send it to us. I think it's typically within 24 hours of them, seeing the patient. Usually the end of the business day, right? Because that's when they have a time to do it. But yeah, we definitely hear from providers. And they do report frequently to us. And then in terms of childcare settings, we hear from a lot of different school nurses and settings throughout the day. So whenever you get once, let's say a school nurse or whoever, an administrator has decided, oh, okay, we're having an outbreak of something, we'll typically hear from them throughout the day. And then is there a scenario where a CBO would be penalized for not reporting? Again, we are not, as Dustin mentioned, we're not the regulatory body. But we would recommend that if you are licensed by some licensing authority, to let them know that you do have an outbreak and you're working with public health on that. I don't think that's something typically that the licensing board wants to find out after the fact that you had an outbreak. So we typically recommend people let their licensing bodies know that there is an outbreak and that you're working with public health.
I think there was a clarifying question about going back to what was mentioned about the providers report. It was healthcare providers. There we go. Does anyone else have any other questions? Hands here, just double checking. No other questions? Okay. Well, we don't have any further questions. Any last thoughts, comments, questions, concerns? Okay. All right. So just want to thank Dr. Trivedi and Dr. Locke for sharing us these updates, and also for Sabrina and Dustin for also your support as well, and Alameda County Public Health Department for bringing us this wonderful presentation. I also want to thank everyone for joining us today. Just want to keep a reminder to keep an eye out. There will be an email with a post survey. We do appreciate your feedback. It helps us to look at our trainings and quality of our trainings. And also there are upcoming trainings, perinatal mental health, a Spanish training coming up also in this month by Dr. Gloria Castro. So you're welcome to check out our calendar. And also all the links that were mentioned and that were provided for the presentation are also in the chat. So I'll leave that up there, and the PowerPoint for this presentation will also be sent through via email, and the recording as well. So that'll be coming in sometime in about a week or so. So thank you, everyone. Thank you again.
Catherine,
Oh,
so
yes.
sorry to interrupt. Thanks everybody so much for being here. I just want to reiterate that with the video being sent out, as you can see, it's sort of a small group here today, and we really want to amplify the message. So please, spread the word, share the video with your extended ECE community and other staff members and organizations, providers that you think could benefit from today's talk. So thanks so much.
Thank you, Sabrina. Appreciate that. Thank you, everyone. If there's no further questions, we'll see you next time. Thank you. Have a nice day, folks.
Bye.
Bye-bye.
Good weekend, everyone.
Yeah.